I'm Dr. Purba. Would like to introduce my paper about cost-effectiveness of culture-based treatment versus empirical antibiotic treatment for hospitalized adults with community-acquired pneumonia in Indonesia. And this is a real-world patient database study. Community-acquired pneumonia is an infectious disease with a clinical severity ranging from mild to life-threatening, and community-acquired pneumonia has high mortality rates and is costly to treat. In the US in 2012, the total direct medical costs related to community-acquired pneumonia were estimated at $7,000 to $11,000, and in European countries the cost was estimated to be between 1,200 and 1,500 euro per patient. These high costs have been partially attributed to multiple antibiotic resistance. The implementation of culture analysis is in developing countries with a high prevalence of community-acquired pneumonia, such as in Indonesia, should be considered alongside the assessment of culture analysis impact on cost and patient life expectancy. The culture analysis approach has rarely been adopted in hospitals or in communities due to the lack of evidence for cost effectiveness. And the study analyzes the cost-effectiveness of culture-based treatment versus empirical treatment in hospitalized patients with community-acquired pneumonia. A decision tree model was designed from individual patient data of hospitalized community-acquired pneumonia patients in Indonesia with a payer perspective. The decision tree compared two options. The first is patient with empirical antibiotic treatment during hospitalization, and the second one is patients with culture-based treatment for whom medication were adjusted based on microbiological evaluation in terms of the culture and antimicrobial susceptibility test. We called this group was culture-based treatment. Also, we assessed the rates of antibiotic change and the outcomes such as recovery and mortality rates, and also the total cost. The implementation of culture-based treatment improved life expectancy over empirical treatment groups, 250 in all cases, and 600 years in the elderly groups, and 290 years for patients with PSI class 3 or more, and 515 years for ICU patients. The implementation of culture-based treatment over empirical treatment from a payer perspective. The cost of culture-based treatment was cost-saving $1 million for all cases, and $3.8 million in the elderly groups, and $980,000 for patients with PSI class 3 or more, and $1.8 million among ICU patients. In conclusion, community-acquired pneumonia patients undergoing treatments based on culture analysis were estimated to receive benefits in terms of cost savings and increased life expectancy than those with empirical treatment during their hospitalization. Culture-based treatment was labeled dominant compared to empirical treatment, and the implementation of culture-based treatment provides considerable advantages for patients aged 60 or above, as well as for higher severity classes. In severe community-acquired pneumonia cases, cultures can adequately guide antibiotic selection for patients with severity class 3 or above, or who are hospitalized in ICU. Thank you very much.